Hello, my name is David Rizik, Chief Scientific Officer and Director of Structural and Coronary Intervention at the Honor Health Medical Center in Scottsdale, Arizona. I'm also the Associate Editor of SCAI, the Journal of the Society for Cardiovascular Angiography and Intervention. I am honored to represent SCAI and our Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jscai.org, that's JSCAI.org, or follow us on Twitter at myJSCAI. JSCAI is the home of all official SCAI documents. Here today, we have come together to discuss an important document published in JSCAI titled Novel Lithotripsy-Assisted Transcatheter Aortic Valve Replacement May Reduce Risk of Aortic Root Rupture. This is an exciting paper, and I'm delighted to be joined by an esteemed group of panelists. First, Dr. Puvi Seshiah from the Heart and Vascular Institute at Christ Hospital in Cincinnati, Ohio. Dr. Dean Kereiakes, President and Medical Director of the Christ Hospital and Vascular Institute and Professor of Clinical Medicine at The Ohio State University. And we are also joined by Dr. Suzanne Baron, the Director of Interventional Cardiology at the Massachusetts General Hospital in Boston, Massachusetts. To all of you, thank you for joining. I'm going to turn this over to Dr. Seshiah to start the conversation and to give us an example, a really concrete set of examples on why this is important.
Good evening, and thank you for having me. Everything that we do in medicine starts with a story. Our story always is a case that makes you stop and think and figure out how to help patients. So our first patient that made us stop was a 78-year-old gentleman. He had severe aortic stenosis. He is a Vietnam veteran who was exposed to Agent Orange. He had an STS of 4, but did not want surgery due to PTSD symptoms. And so he had a aortic valve that was severely stenosed. His maximum velocity was 4.7 meters. His mean gradient was 48. He had moderate coronary disease. And on a CT analysis, his annulus was 588 and his LV outflow tract was 592. His sinuses were large and he sized to a 23 S3 valve. But what made us pause was the amount of calcium on the leaflets. His calcium score was over 5,000, and the distribution of calcium was even on his leaflets. So when we see this amount of calcium, we don't use the company recommended 10 to 20% oversize, and we decided to go with a 29 S3 with 1 cc's reduced from what was recommended. This would give us a annular oversize of about 5 to 7%. So uneventful crossing of the valve. We had no difficulty delivering the valve in place. We did not pre-dilate. So the valve is deployed. And as you can see on this slide, as we deployed this valve, the pigtail had a very abnormal shape. We felt that the leaflet was calcified, probably had a horizontal motion instead of a vertical motion, and instead of opening up, ended up going horizontally into the aortic root. And you'll watch that pigtail take an abnormal bend on it. And so the next image shows a frightful complication. The aortic root had a perforation. In fact, it was not an annular rupture. It actually turned out to be a aortic root perforation by a shard of calcium from the aortic valve. We got him stabilized on the bypass circuit. Our surgeons were able to find the spot that had a perforation. They were able to repair him. Unfortunately, he developed multi-system dysfunction, ultimately ended up on dialysis, and he and his family did not want to pursue dialysis, and he expired 7 days after this procedure. So this made us pause because we had contemplated about what valve to use in this gentleman prior to deployment. And the always logic when you see that kind of calcium is to go with a self-expanding valve. And again, we've all had this experience. This is a patient with similar heavily calcified valve. This was a 86-year-old lady. We pre-dilated this valve with a 22 true balloon. And then you can see on your second frame there, 80% of the evolute valve frame is deployed, but the valve is completely compressed by the leaflets. This, we took that valve frame out, redilated the aortic valve with a 24 balloon. And all the while we were nervous, that amount of calcium with the 24 balloon, how much injury are you causing to the root and to the valve? She became quite unstable with a lot of AI. So we went back in with the same valves as a 29 evolute. And you can see on the third frame, even after deployment, the valve was constrained. So the valve was constrained. And if you look along the medial border, the valve had deformed. You can see infolding on the valve frame. And we thought we could post-dilate this. So on the last image, we post-dilate the valve frame. The valve expands. The valve infolding gets better, but the moment we release the balloon, you see the valve go back to the deformed shape. But fortunately, this patient did well. She had no significant AI. Her gradient was about 6. Given that she was in respiratory distress, we figured she will get better. She did get out of the hospital 3 days after this, but it goes to show that self-expanding valves are not the solution for severely calcified valve leaflets either. So we went back and we thinking about how to treat these patients in going forward. As right at this time, Shockwave released their larger balloons. They called this the L6 balloons because of 6 emitters in the balloon. And the largest of their balloons is 12 millimeters. So we surmised that if we could deploy this balloon and deliver the shocks to the valve, maybe we will make the valve leaflets more compliant. And there is some evidence that this works in other areas. So we the slides on the right side show evidence of this in the mitral space. There have been our group and several other groups around the country have shown that in patients with mitral stenosis, pre-treating the mitral stenosis, even with a lot of calcium with Shockwave, followed by balloon valvuloplasty, they got excellent midterm results. And we published a case a year ago, very similar with heavily calcified mitral valve. We pre-treated this valve with what was available at that time, which was the M5 peripheral balloon. These are 2 8-millimeter balloons. We pre-dilated the valve, delivered shocks to the valve frame, valve leaflets, and subsequently deployed the Medtronic Intrepid valve frame with excellent results. And so we thought maybe we could apply this to the aortic space. There is some benchtop testing that confirms that Shockwave lithotripsy works on calcified leaflets. A group out of Italy had developed a lithotripsy device, which is meant for aortic valves. And in their benchtop testing, they applied lithotripsy to the valve leaflets. The histology of these slides is shown on the left side of this slide. So the untreated valve leaflets, when they process this, the calcific nodules come out of the tissue. So all you see is a hollow space where calcium was present before. But in treated valve leaflets, you can see destruction of the calcific nodules. All the dark staining is calcium that has been destroyed into the tissue. So there is evidence that lithotripsy works on the leaflets as well, and possibly making them more pliable. And so we thought we could potentially use this technology in the TAVR space. So the evidence for use of shockwave comes from their own benchtop testing. The L6 balloon has 6 emitters. They are bigger emitters than the M5 Plus. So the depth of the lithotripsy current is up to 30 millimeters. We can treat them up to 26 millimeters from the center of the balloon. And in a typical aortic valve, that is adequate treatment zone. It treats to a 30 millimeter length and a 26 millimeter width space. So your lithotripsy power can extend around a average aortic valve, annulus, and leaflets. So our next subsequent patients that came to us with calcium score that were very high, the patient one was a 90-year-old gentleman with severe AS, annulus of 534, LV outflow tract of 539, and large sinuses. He had a calcium score of over 5,000. And similarly, the patient in the bottom 2 slides had a calcium score of 4,900. He was 77 years old. Annulus was 628. LV outflow tract was 639. And this gentleman sized to a 29 valve. The 90-year-old gentleman sized to a 26 valve. And so we decided we should shockwave these patients before delivering of the valve. So the next comes the logistics of delivering a shockwave balloon. One of the things with the L6 balloon is it takes a whole minute to deliver shocks, each 30 cycles of shock. So patients will become unstable if you try to deliver all those shocks. So what we felt was, since the balloon is only 12 millimeters, maybe we can deliver this without rapid pacing. But to prevent the balloon from shifting, we had to make sure we had stable control of the balloon. And also the balloon is delivered over a 0-8 wire. Here we crossed the valve as usual, and then delivered a JR4 guider into the left ventricle. And over this guide, we delivered a platinum plus wire, which is an 0-8 wire. And again, we shaped that wire into a nice pigtail curve to keep it stable and safe. Now, to bring the valve, to keep the valve very stable across the arch, we advanced what was a tip deflecting sheath. The L6 balloon will go through an 8 French sheath. So we used a 10 French Oscar sheath. The patient had a Sentinel device placed. We had the 16 French E sheath in the groin, and through this sheath, we delivered a Oscar, which is a tip deflecting sheath. Any of those tip deflecting sheaths would work. And so once we had the tip deflecting sheath in the ascending aorta, we were able to deliver the L6 balloon and inflate and deliver the shock without rapid pacing. And this is important because the shock wave takes a whole 30 seconds to deliver its shocks. And so patients become unstable if you rapid pace them. So we did this without rapid pacing by keeping that tip deflecting sheath in place. So here comes the delivery of the S3 valve. This was a 26 valve. And when the pigtail motioned the same way as our first patient, we were a little worried, but the patient did well. He had, I would say, mild PVL after the case, and he went home the next day. And our second patient did the same way. He had a 29 valve deployed without any difficulty, and both of them did very well with the shockwave before TAVR. So, severely calcified valves pose a big challenge for us. We don't know why that happens. There's all sorts of links to lipoprotein A, elevated lipids, but we don't know why some patients get a lot of calcium on these leaflets. But it puts a high risk of rupture with balloon expanding valves. And as we've shown, self-expanding valves don't necessarily work in this space either. So we demonstrated that lithotripsy of the aortic valve could help deploy these TAVR valves by making the leaflets more pliable. And this was shown ex vivo by the Italian group. And what is to come in the future is probably a dedicated shockwave balloon trial, or maybe a device that is designed for an aortic and mitral space. And we're just not sure where these companies are in terms of manufacturing, but this is a balloon that's available to us off the shelf and should be used if you run into difficulties with calcific aortic valve.
This is really great stuff. Very interesting. After I spoke to Dean about this, I had to try it on a very heavily calcified valve. Suzanne, as you look at this, the most difficult part for me is that no one wants to do valvuloplasty anymore. Who's doing valvuloplasty? Are you doing valvuloplasty?
You know, it's an interesting thing. I've really not done a standalone valvuloplasty probably in 7 or 8 years at this point. I am doing valvuloplasty in the setting of either advancing, need to advance a support device like an Impella device across patient with severe AS, or obviously to pre or post-treat for TAVR. But I haven't done a standalone valvuloplasty in many years.
What about as a lesion pre-treatment strategy for self-expanding or even for S3?
Absolutely. Yes. No. So for pretreatment, for sure, as needed in patients who either have very severely elevated gradients or have very, severely calcified valves. But it's certainly just as we described here, it definitely gives you pause because you start to be concerned about what is the increased risk that you're putting the patient at as far as stroke or other embolic phenomenon or annular disruption.
Dean, is there a calcium threshold above which it would encourage the use of lithotripsy, or is this sort of like, I just know it when I see it?
I'll tell you, David, we don't know that. We arbitrarily and empirically, Puvi and I have talked about this. We think probably at least 2x what we call. So for the 2,000 in the male, for at least 4,000, and both these guys were hanging around 5,000 or more. And I mean, that's severely calcified. In women, we would say 2 times 1,200 be 2,400, 2,500, 3,000 in a woman would be
severe.
Yeah. And so I think that's probably the target. And we just don't know how they behave. That leaflet would behave like a saucer.
Right.
Just sick instead of folding. So we thought that if we can alter the compliance through fracturing calcium in the leaflets, we could maybe get the leaflets to do more of this and less of this.
So the treatment zone is 26 millimeters. I've heard other people talking about putting 3 of the M series balloons in there and trying to do it. Not a good idea, dangerous idea.
It's doable. It's the logistics of delivering 3 different balloons into that space. And if you are using more than 2 M5 plus balloons, you need a minimum of 12 French, maybe 13 French device.
Or multiple access sites.
Correct.
Or
multiple access sites. And so that makes that a little bit more difficult. And of course, the cost of it, each balloon is about $3,000, and you're now making a case for 3 of these M5 plus balloons. Luckily, the L6 balloon, goes up to 12 millimeters, and I think that can obviate the need for using 2, maybe 3 balloons. In the mitral space, the issue will become, because the annulus in men tends to be large, and I don't know what the L6. We have not had any experiences using L6 in the mitral space, but we'll probably do it one of these days when a case comes. But it's just one of those that will 12 be enough. I suspect it may be enough in a woman, but I'm not sure about men, just because how large it is.
Suzanne, this was a lesion pretreatment strategy. Could you envision a valve that is constrained, say a core valve or self-expanding nitinol valve that's constrained, in which you might use this as a post-deployment strategy. We've done this with coronary stents.
I was just going to say, we do it with, I mean, I know it is an off-label thing and it's not, we're supposed to, but in the cases where, every once in a while you've got a dog bone after you've put a stent in, and I've gone ahead and I have done IVL to further, or high pressure OPN balloons to further deliver. So I think that's certainly possible. I think the other thing that you start to think about is, we know that there are companies out there that are looking at, doing something similar as just a standalone treatment of using devices to score the leaflets themselves.
Leaflets, like the leaflets.
Yeah, exactly. And so would this be something that, is something that we would consider doing for patients that we're just trying to buy them some time until they get their valve, whether it's to get them through a surgery before we can TAVR them, or, something else that may be a possibility. So
I like that idea.
Yeah.
73-year-old patient that, has AS, and you're just wanting to get them to 78 so that you can get them a TAVR at that age. Yeah, absolutely. I mean, it's a great, this field will open itself to so many options for these patients. And you're the 12 millimeter balloon, maybe 14 if they come up with it. You're not afraid of destroying the valve and causing severe AI, and you're not worried about rapid pacing either. So it's very interesting where this is going to go.
Dean, as we go forward, this was all shockwave and less balloon compression. Would your advice to industry be a somewhat larger balloon so that you get the combination of the sonic shockwave effect, but also some degree of balloon compression?
The 7 millimeters on each side of the inflated balloon is conservative if you talk to the shockwave chief of engineering. So it's at least a 26 millimeter cylinder that's treated here with a 12 millimeter balloon. A 14 would be, significantly larger, and I think would encompass most of the aortic valve. That, maybe you use that for a large valve. The point I want to make, though, I'm not sure you need to use an Oscar guide. And in fact, you and I talked about that, and I said maybe use multipurpose, either.
And that's exactly what I did.
And I think that'll work just as well. And through an 8 French, you could seal that with a seal if you wanted from an alternative access. So
yeah, we
how'd that work, Dave?
Beautifully. Actually, I'd love to show you those slides, because I guess I was a little surprised. I didn't think I was going to get as much calcium segmentation as we actually saw. And 2 of the leaflets were stuck in place. And we saw pretty good segmentation of the calcium and restoration of leaflet mobility. And this was as a TAVR pretreatment strategy. I'd like to go back to the histology slides. Maybe we could do a little bit of a deeper dive. What exactly are you seeing on those histology slides?
So this was a very nice study. It's in one of those smaller journals called Frontiers in Medicine or something like that. But this group, their goal was to make a device, and it's along the same lines of lithotripsy of the aortic valve. They wanted to make a device that you could use for all that we talked about, just de novo treatment of the valve without putting a TAVR valve, or even pre-treatment. And so they made this device. It was bulky, but they needed to test it out. So they took native aortic valve leaflets, mounted them on in a bath, and then applied IVL to them. And when the slides were processed, the ones untreated, the calcium just comes off because it's hard, and the tissue remains. Whereas in the lithotripsy treated specimen, they saw destruction of the calcium in the tissue itself. All that dark staining is calcium that's been destroyed. And I wonder, if you think of nodules as being stiff, bony-like structures inside the valve leaflets, by breaking them up, clearly you make these leaflets more pliable. And I think this goes along our thought process in coronaries as well as in peripheral vascular space, where when we treat these lesions with IVL, the vessel becomes more compliant, and I think this should apply to the valve leaflets as well.
It's just tremendously interesting stuff. Dean, give me your closing comments.
Well, I think modification of calcium is panvascular. I mean, this is, we've entered an era where we need tools to modify calcium to prepare the space for other devices, whether it's a stent, whether it's a valve. And I think that's, we don't have all the tools. We are cobbling together what we have. And so far, we've had a really good experience, both in the mitral space, where we did the first, transeptal intrepid into that calcium score 7,800, the mitral annulus, with the picture that Puvi showed. I mean, it's really a phenomenal case. And we showed continued progressive expansion over 90 days, also on CTA, from pre-discharge 30 days, 90 days. And this, in the aortic space, I think makes a lot of sense. I know there are other technologies being devised, but nothing could be more simple than this. You put the 18 wire adjacent to your Safari wire, and you just go right along. We blew it up. And we really, it's remarkable how stable the patients were. Weren't you?
That was the good part until we had to pace, because we did have some to and fro movement, but I just advanced the guide catheter as you suggested behind it, and it kind of stabilized it.
And stable. And you also don't have to do 30 seconds. You can do 10. You can do exactly, and just, I mean, you've got X number of pulses. You just give as many as you think the patient will tolerate. And on one of those cases, we may have paced a couple times, but in general, if you lean down on the guide, you can keep the balloon there, kind of like the bucking bronco phenomenon, and keep it on the target.
Suzanne, you get the final word. It's several years into the future. You have a series of lithotripsy / valvuloplasty balloons. How often are you going to use this based on your clinical practice today?
One of the things I was thinking about, so I haven't actually gotten to do this technique yet, but I'm already thinking of a patient that I've got coming up who has a valve calcium score of almost 6,000 that I've been sweating about. So I say yet right now, because this is certainly going to be something I'll discuss with the team. But, I'm starting to think, just while we were talking here, about all of the patients, who are bicuspid, that we're treating more and more with these fused bicuspid leaflets or true bicuspids. And we're seeing that more and more and more. And we're also seeing, I think, a bit of a heavier burden of calcium as we see more patients, coming through with dialysis and things like that. I could imagine this really having a significant place in our toolbox, either as a pre-treatment before we place our actual TAVR valve, or again as a standalone as a way to prolong our time from TAVR to TAVR to TAVR.
Wow, what a great panel! What a great discussion! What a great topic! I'd like to thank you for joining us at Conversations in Cardiology. You can find us online at jscai.org. That's JSCAI.org, or follow us on Twitter at myjsci. JSCAI is the home of all official SCAI documents. Thank you to our panel, and thank you for joining us.